Welcome to today's webinar. I'm your host, Dr. Mike Lenore. We're so pleased to welcome Dr. Autumn Burnett to discuss asthma rescue therapy. Dr. Burnett brings an amazing experience as a speaker on virtual CME podcast, webinars, live national broadcasts. It is an honor to have such a highly sought after speaker with us here today. Dr. Burnett completed her allergy fellowship at the University of Virginia, going on to treat both children and adults as a physician and assistant professor of allergy and immunology at Howard University in Washington, D.C. She's board certified in both allergy, immunology, and pediatrics, and achieved an appointment as a fellow of the American College of Allergy, Asthma, and Immunology. Dr. Burnett focuses her clinical interest in the areas of hereditary angioedema, urticaria, asthma, and atopic dermatitis, with a special expertise in biologic treatments. Dr. Burnett has served as a primary author and co-author in several peer-reviewed journal manuscripts and oral abstracts, and has extensive experience as a consultant and advisor across allergic and immunologic disorders. And now, I proudly present to you Dr. Burnett to give us some fresh insights on reframing rescue therapy to help prevent asthma exacerbations.
Short exacerbations. Hello, and welcome to this AstraZeneca presentation, Reframing Rescue Therapy to Help Prevent Asthma Exacerbations. My name is Dr. Autumn Burnett, and I have been practicing medicine as an allergist in the asthma space for about 15 years. Thank you for joining us today. Please note this presentation does not qualify for any form of continuing education credit. The objectives for this presentation include the following. Recognize the impact of asthma exacerbations on the burden of disease for patients with asthma in the United States. Gain an understanding of the role of variable airway inflammation in the occurrence of asthma exacerbations and the consequent burden of systemic corticosteroid exposures. Appreciate patient preferences for immediate symptom relief and fewer asthma attacks. Review recent recommendations from the Global Initiative for Asthma, or GINA, and the National Asthma Education and Prevention Program, or NAEPP. And finally, examine data on a rescue therapy treatment option. When it comes to the science of asthma in the United States over the last few decades, how do you think we're doing? Well, let's look. The prevalence of asthma in the United States continues to increase, as you see represented here along the gray arrow. The latest CDC data from 2021 estimated that approximately 25 million people had asthma. From 2000 until now, several new therapies have been approved by the FDA for asthma. Fixed-dose combination inhaled corticosteroids plus long-acting beta-2 agonist inhalers, an anti-IgE monoclonal antibody, long-acting muscarinic antagonist inhalers, monoclonal antibodies inhibiting interleukin-5 or interleukin-5 receptors, a monoclonal antibody inhibiting IL-4 and IL-13 receptors, a fixed-dose combination ICS-LABA/LAMA, a thymic strongyl lymphopoietin antagonist, and most recently, a fixed-dose combination short-acting beta-2 agonist plus inhaled corticosteroid inhaler. So we clearly see that major scientific discoveries have been made surrounding asthma. And these type of discoveries have generated multiple updates by GINA and the NAEPP, as shown here, going back to 1991 and bringing us to the most recent update published by GINA. Yet, the burden of asthma persists. It is puzzling that severe exacerbations still contribute to asthma morbidity, including hospitalizations, emergency department visits, and use of corticosteroids, despite numerous advancements for the treatment of asthma. To fully appreciate the burden of a severe exacerbation It is important to define severe exacerbation, which is a clinical deterioration of asthma with a worsening or a new onset of symptoms leading to at least one of the following events: treatment with or an increase in systemic corticosteroid in association with a healthcare provider encounter, an ED or urgent care visit resulting in systemic corticosteroid treatment, hospitalizations with systemic corticosteroid use or intensive care unit admission or intubation, and finally, death. Now let's examine the impact of severe exacerbations in the United States. A retrospective study, which evaluated claims data from 2012 to 2017 of over 435,000 patients 12 years of age with persistent asthma, identified that nearly 2/3 of these patients received oral corticosteroids during a follow-up period. For patients with asthma, data from the CDC in 2020 showed an estimated 990,000 annual emergency department visits and approximately 95,000 annual hospitalizations due to asthma. Moreover, in 2021, approximately 9.8 million attacks were reported by patients in the United States with asthma. To help address this burden, NAEPP and GINA support a shift in the rescue paradigm. As an allergist, I always feel it's important to go back to the fundamentals of airway inflammation to explain how it contributes to symptoms. Airway inflammation is central to asthma symptoms and exacerbations. In patients with asthma, we can see tightened airway smooth muscles, airway wall swelling, infiltration with inflammatory cells, mucus gland hypersecretion, and a thickened subepithelial basement membrane with fibrosis. These changes can result in airway luminal narrowing and asthma symptoms. And importantly, the inflammation and symptoms of asthma vary over time and intensity and can lead to asthma exacerbations. Let's take a deeper look into how key asthma therapies affect the airway and help address asthma symptoms and inflammation. This slide helps to illustrate how short-acting beta-2 agonists, or SABAs, treat symptoms through bronchodilation, while inhaled corticosteroids address underlying inflammation and enhance the effects of SABA. SABAs bind to beta-2 adrenergic receptors on airway smooth muscle cells, producing airway smooth muscle relaxation. On the other hand, inhaled corticosteroids are known to reduce airway inflammation and augment bronchodilation through mechanisms that include both late-phase genomic and early onset non-genomic effects. We often think of inhaled corticosteroids as having a delayed onset due to genomic effects, which include the activation of glucocorticoid receptor to alter gene transcription through direct DNA binding, or modification of transcription factor activity. These late effects, which have an onset of 4 to 24 hours, include the following: increased anti-inflammatory gene transcription, decreased pro-inflammatory gene transcription, and increased beta-2 receptor gene transcription. However, inhaled corticosteroids have also been shown to exhibit non-genomic effects, which are characterized by a rapid onset that occurs within minutes, as well as a short duration of action. Such early onset effects include the following: amplification of beta-2 agonist-induced bronchodilation, decreased bronchial vascular blood flow due to the direct effect of increased norepinephrine, and suppressed immune mediators. When ICS is used as a part of an asthma maintenance therapy regimen, we rely on maintenance to help keep inflammation in check. However, as we discussed earlier, inflammation and symptoms vary over time and in intensity and can lead to an exacerbation. Let's explore this concept further. Patients with asthma experience episodic exposures to allergic and non-allergic triggers that can lead to variability in inflammation and symptoms. treatment with an anti-inflammatory maintenance therapy is intended to address baseline levels of inflammation, as shown by the dashed line in the illustration. However, maintenance therapy may not always be able to address changes in inflammation. Rising inflammation may cause airway narrowing, decreased lung function, and increased symptoms, and can lead to an exacerbation. Increasing symptoms prior to an exacerbation may lead patients to increase their use of rescue medication. Here on the left, we present a figure from that FACET study, an exacerbation reduction study, in response to inhaled corticosteroids with or without a LABA. This work examined the pattern of peak expiratory flow decline, symptoms, and rescue beta-2 agonist use in the 425 exacerbations that occurred during the study. You can see that peak flow fell while symptoms and rescue use increased in the 10 days before the exacerbation was diagnosed, and they returned to pre-exacerbation or near pre-exacerbation levels over the subsequent 2 weeks. As asthma symptoms worsened prior to an exacerbation, patients increased use of their fast-acting bronchodilators. Use of an as-needed fast-acting bronchodilator without inhaled corticosteroid to treat symptoms does not address underlying rising airway inflammation, thus further worsening symptoms, and the need for rescue bronchodilators can occur. Rising inflammation can result in decreasing lung function, as well as increasing symptoms and rescue therapy. This concept was further explored in a medical and pharmacy claims real-world study. Meredith market scan administrative claims data from 2010 to 2017 identified over 300,000 patients aged 4 years and older with moderate to severe asthma as defined by fills of GINA step 3 through 5 maintenance therapies. The graph on the right provides data from the subgroup of over 37,000 patients greater than or equal to 12 years old that experienced a serious exacerbation during the study, and showed that an escalation in both SAMA and maintenance fills occurred in the days leading to serious exacerbation, and that greater than 40% of patients did not have a maintenance medication fill within the month prior to a serious exacerbation. It is important to note that serious exacerbations in this analysis were a subset of severe exacerbations that were accompanied by an in-person, face-to-face healthcare provider encounter in an outpatient clinic, urgent care or ER visit, or hospitalization. These studies provide support that a window of opportunity may exist to help prevent an exacerbation if symptoms and inflammation are treated concomitantly. The INSPIRE study from 2006 identified patterns of rescue and maintenance use and examined patient attitudes towards asthma management. This study examined the attitudes and actions of 3,415 patients in 11 countries, including the United States, aged 16 years of age and older, with physician-confirmed asthma, who were prescribed regular maintenance therapy with ICS or ICS and LABA. Structured interviews were conducted to assess medication use, asthma control, and patients' ability to recognize and self-manage worsening asthma. In this study, 38% of patients believed that there was no need to take medication every day, while 90% wanted immediate relief when symptoms occurred. Although most patients recognized the early signs of worsening, the most common response was to increase short-acting beta-2 agonist use. As we know, worsening symptoms can progress into an exacerbation, which may lead to systemic corticosteroid therapy. While treatment of exacerbations with systemic corticosteroid is often necessary and effective, observational data have suggested that standard bursts of systemic corticosteroids may result in a cumulative steroid burden impacting future health. Shown here is data from an observational study by Price and others demonstrating the potential risks of developing adverse health conditions due to varying levels of cumulative systemic corticosteroid exposure. The risk of developing conditions such as diabetes, anxiety, and depression as a result of systemic corticosteroid use increased as exposure to systemic corticosteroid accumulated over a lifetime. Shown here, statistical significance was evident when cumulative lifetime systemic corticosteroid exposure reached a threshold of 500 milligrams to under 1,000 milligrams. A greater risk occurred and more adverse conditions emerged, such as osteoporosis and cardiovascular disease, between the 1,000 milligram and less than 2,500 milligram of cumulative systemic corticosteroid exposure. In a separate retrospective cohort study and self-control case series, it was observed that within 30 days of oral corticosteroid initiation, the incidence of adverse events such as sepsis, venous thromboembolism, and fracture approximately doubled. Thus, treatment with exacerbations with systemic corticosteroids contributes to the burden of disease that may affect future health. You might be wondering, how easily can you reach the 500 or 1,000 milligram levels in a clinical practice? Based on recommendations from GINA and the NAEPP Expert Panel Report 3 from 2007, where a range of systemic corticosteroid dosing options are provided, even with one burst, a patient could be exposed to or even exceed that 500 milligram threshold, as shown starting with the yellow in the bottom right of the first column. With a second burst, many patients would reach exposure levels of at least 500 milligrams, with some even reaching at least 1,000 milligrams, as shown in the red at the bottom right of the second column. And with a third burst, most patients would have reached a cumulative threshold where their risk for chronic adverse health conditions is significantly increased. Keep in mind, this is illustrative of the use of systemic corticosteroid for asthma and does not include other cumulative exposures patients may receive for the treatment of other conditions. In real-world use, it can be quite difficult for clinicians to track cumulative lifetime systemic exposures, as electronic medical records are often incomplete. Treating symptoms and inflammation concomitantly with rescue or reliever therapy that includes both an ICS plus a fast-acting bronchodilator is supported by the latest recommendations from GINA and NAEPP. As a reminder, SABAs and formoterol are considered fast-acting bronchodilators. In fact, NAEPP guidance from 2020 incorporates this concept at steps 2, 3, and 4 as preferred therapy, with concomitant as-needed SABA plus ICS, a recommended option at step 2, and ICS formoterol maintenance and rescue at steps 3 and 4. GINA also supports this approach with ICS formoterol as the preferred reliever across all treatment steps in track 1. In GINA, SABA-only treatment of asthma is no longer recommended. Also, GINA states the risk of severe exacerbations and mortality increases incrementally with higher SABA use independent of the treatment step. It is important to remember that the use of ICS formoterol is not approved in the United States for maintenance and rescue therapy or for as-needed rescue only. The recommendations for ICS formoterol are based on clinical data evaluating the use of ICS formoterol formulations and strengths not approved and not available in the United States. GINA 2023 includes recommendations for the concomitant use of SABA and ICS in its track 2 controller and reliever treatment steps for patients of all disease severities. As can be seen, the reliever options recommended in this track are as-needed ICS SABA or as-needed SABA. GINA also states that before considering a regimen with SABA reliever, check if the patient is likely to adhere to daily controller treatment. GINA emphasizes the importance of a personalized asthma management plan involving a continual cycle of assessment, adjustment of treatment, and review. The plan should be developed according to an individual patient's needs in order to achieve the goals of asthma treatment. If we treat symptoms with ICS-based rescue on top of maintenance therapy, will that lead to excessive ICS exposure? This question was evaluated in a real-world claim study, which assessed estimated daily ICS exposure if ICS was included with each use of SABA, relative to the maximum FDA-approved daily ICS doses for each NAEPP step of ICS therapy. Using the Meritive market scan databases, administrative claims for United States patients with commercial Medicaid and Medicare coverage, more than 500,000 patients aged 12 and older were identified between 2010 and 2017. These patients had 12 months or more of continuous benefit enrollment before and after a SABA index fill date and no evidence of any non-asthma chronic conditions commonly treated with systemic corticosteroids. All doses of ICS were expressed in micrograms of fluticasone propionate equivalents, with 50 micrograms of fluticasone propionate equivalent to 80 micrograms of budesonide. Patients were categorized according to the most common maintenance medication filled during the 12 months post-index period. Shown in the maroon shaded ovals above the bars are the maximum FDA-approved daily ICS doses in micrograms of fluticasone propionate equivalents, with hydrofluoroalkane preparations in the lighter color and dry powder inhalers in the darker maroon. Below, the yellow-colored portion of each bar represents the observed daily ICS exposure for each maintenance therapy as measured by the proportion of days covered. The dark blue portion of each bar represents the projected additional daily ICS exposure if a dose of ICS was added every time a SABA was used. As illustrated with each maintenance therapy, the mean estimated daily ICS exposure did not exceed the respective maximum FDA-approved levels based on usage patterns for ICS and SABA. The total estimated ICS exposure for maintenance plus as-needed ICS would range from 36% of the respective FDA maximum approved dose in the high-dose ICS LABA group to 100% in the low-dose ICS group. This study also evaluated systemic corticosteroid exposure based on claims data and compared it to the annual total estimated ICS exposures in milligrams. The table shows us that the annual mean systemic corticosteroid exposure was greater than the estimated exposures from ICS. As you can see in the top row, the annual estimated mean ICS exposure ranged from 22 milligrams in the SABA-only group to 148 milligrams in the ICS LABA-LAMA group. In the second row, you can see that approximately 32 to 56% of patients receive systemic corticosteroid treatment across treatment groups. The third row indicates that for all patients receiving maintenance therapy who had systemic corticosteroid exposures, the mean annual observed systemic corticosteroid exposure was greater than 500 milligrams, exceeding the threshold we discussed earlier, which has been associated with an increased risk of adverse health conditions. For those patients in the SABA-only group, the mean annual observed systemic corticosteroid exposure was 451 milligrams per year. When the two annual exposures were compared, the observed systemic corticosteroid exposure relative to the estimated inhaled corticosteroid exposure was at least 6-fold higher in groups receiving maintenance therapy. And for those on SABA-only therapy, it was 21-fold higher. Now the puzzle of asthma burden is starting to come together. Let's recap the pieces we've discussed so far. We know that inflammation and triggers vary and that maintenance therapy may not fully address these fluctuations. In addition, exacerbations persist even with the use of maintenance therapy. We've shown how guidelines and expert opinion recommendations are updated as the science evolves, and that the expanded management and treatment options require broad education and implementation. Thus, the question remains, can the puzzle be solved? We will now transition to a review of clinical data for AirSupra a fixed dose combination medication where each inhalation consists of 90 micrograms of albuterol and 80 micrograms of budesonide. AirSuper is a therapy that was designed to shift the treatment paradigm and help address the problem of exacerbations for patients with asthma. Please see the full prescribing information, including patient information for AirSuper, available at www.airsuper.com or at www.azpicentral.com. AirSuper was approved by the FDA in January of 2023, and it is a combination of albuterol, a short-acting beta-2 adrenergic agonist, and budesonide, an inhaled corticosteroid. AirSuper is indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age or older. The recommended dose of AirSuper is 180 micrograms of albuterol and 160 micrograms of budesonide, administered as 2 inhalations of AirSuper, albuterol/budesonide 90/80 micrograms. Patients are instructed not to exceed more than 6 doses or 12 inhalations in a 24-hour period. Before reviewing the clinical data, let's focus on some select important safety information. Contraindications to using AirSuper include hypersensitivity to albuterol, budesonide, or any of the excipients. Deterioration of asthma can occur acutely or chronically. So if a patient continues to experience symptoms after using AirSuper or requires more doses of AirSuper than usual, it may be a marker of asthma destabilization. AirSuper can produce paradoxical bronchospasm, which may be life-threatening. If paradoxical bronchospasm occurs, AirSuper should be discontinued immediately. An alternative therapy instituted. When associated with inhaled formulation, it frequently occurs with the first use of a new canister. AirSuper, like other drugs containing beta-2 adrenergic agonists, can produce clinically significant cardiovascular effects in some patients and may need to be discontinued. AirSuper should be used in caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Please see additional safety information and the full prescribing information, including patient information, at the end of this presentation. Let's now review key AirSuper data from the Mandala study, a pivotal phase 3 clinical trial used to support the approval of as-needed therapy with a combination of albuterol and budesonide. The Mandala study was designed to evaluate the efficacy and safety of albuterol in combination with budesonide given as needed, albuterol/budesonide 180/160 micrograms or 180/80 micrograms, with each dose consisting of 2 actuations of 90/80 micrograms or 90/40 micrograms respectively, versus as needed albuterol 180 micrograms each dose consisting of 2 actuations of 90 micrograms as rescue therapy in patients with uncontrolled moderate to severe asthma. This event-driven study enrolled symptomatic patients who had experienced at least 1 severe asthma exacerbation in the previous year and were receiving maintenance therapy to treat moderate to severe asthma, as defined by GINA for greater than or equal to 3 months prior to the study entry. Randomized patients continued their background maintenance therapy throughout the trial. It is important to note that while patients 12 to 17 years of age were included in Mandala, AirSuper is not approved in this age group. Therefore, efficacy results are only presented for adults 18 years of age or older. Since albuterol budesonide 180/80 micrograms is not an approved dose, this presentation will not include results for this arm of the study. In addition, select inclusion criteria for the Mandala trial were as follows: a physician diagnosis of asthma documented for at least 1 year, receiving one of the following scheduled asthma maintenance therapies for greater than or equal to 3 months with stable dosing for 4 or more weeks prior to screening, including medium to high dose ICS or low to high dose combination ICS LABA with or without an additional controller. Options included a leukotriene receptor antagonist, a long-acting muscarinic antagonist, or a xanthine. Pre-bronchodilator FEV1 of greater than or equal to 40 to less than 90% predicted normal and confirmed reversibility to albuterol will also inclusion criteria, along with an ACQ-5 score greater than or equal to 1.5 at visit 2, indicating uncontrolled asthma. Select exclusion criteria included chronic obstructive pulmonary disease or other significant lung disease, systemic corticosteroid use within 6 weeks prior to screening, chronic oral corticosteroid use greater than or equal to 3 weeks of use within 3 months prior to screening, and biologic treatment within 3 months or 5 half-lives of screening. As you can see in the adult efficacy population, 2,940 patients total, baseline demographics were similar between the albuterol budesonide 180/160 microgram and albuterol treatment groups. Overall, the mean age was 52 years, and of the patients included, 66% were female, 82% were white, and 25% were of Hispanic or Latino ethnicity. Baseline disease characteristics were also compared across treatment arms. Overall, the mean pre-bronchodilator forced expiratory volume in 1 second was approximately 63% of predicted normal, with a mean reversibility of about 28%. With respect to the ICS maintenance-based therapies, approximately 30% of patients were receiving low-dose ICS LABA or medium-dose ICS, 40% were receiving medium-dose ICS LABA or high-dose ICS, and 28% were receiving high-dose ICS LABA. About 80% of patients had 1 exacerbation in the 12 months prior to screening, whereas about 20% had more than 1 severe exacerbation. Additionally, the mean ACQ-5 score was 2.6, indicative of uncontrolled asthma, and the mean AQL212 score was 4.6 across treatment groups. Now turning to key efficacy results of the Mandala study for the participants who were 18 years of age and older. The primary endpoint was the time to first severe asthma exacerbation, with severe exacerbation defined as an asthma clinical worsening leading to one of the following: 3-day course of systemic corticosteroids or corresponding single injectable dose, an emergency room or urgent care visit due to asthma that required systemic corticosteroids, or a hospitalization for at least 24 hours due to asthma. Note the divergence between the albuterol budesonide 180/160 micrograms and albuterol arms on the Kaplan-Meier curve shown here. The data shown are for patients 18 years of age and older from the pre-planned on-treatment efficacy analysis, collected while patients were on randomized treatment prior to the treatment discontinuation or change in maintenance therapy. Data was censored at the time of discontinuation or change in therapy. Albuterol budesonide 180/160 micrograms significantly reduced the risk of severe asthma exacerbations in a time to first severe exacerbation analysis by 28% compared to albuterol 180 micrograms, with a hazard ratio of 0.72 and a 95% confidence interval of 0.6 to 0.86, and with a statistically significant p-value of less than 0.001. There were also significant results in the key secondary endpoints of the study. The annualized severe exacerbation rate was reduced by 24% for those receiving albuterol budesonide 180/160 micrograms compared to albuterol. The rate ratio was 0.76 with a 95% confidence interval of 0.62 to 0.93 and a statistically significant p-value of 0.008. Additionally, for patients treated with albuterol budesonide 180/160 microgram, the annualized total systemic corticosteroid dose when compared with albuterol was statistically significantly different, with a p-value of 0.001, with a 32% reduction in mean annualized dose per patient. Now that we have reviewed efficacy results, let's look at safety. Here we see a summary of adverse reactions reported in greater than or equal to 1% of the studied population 12 years of age and older. For albuterol budesonide, 180 over 160 micrograms, the incidence of headache was 4.3%, oral candidiasis was 1.3%, and cough was 1% compared to 4.9%, 0.5%, and 1.1% for albuterol, respectively. The safety profile of albuterol budesonide was similar to albuterol, irrespective of background inhaled corticosteroid dose. Just a reminder that safety data shown are for patients 12 years of age and older. AirSupra is not approved for patients 12 to 17 years of age. To complete the description of AirSupra, the next 3 slides provide additional important safety information. Patients should not exceed the recommended dose. Clinically significant cardiovascular effects and fatalities have been reported in association with excess use of inhaled sympathomimetic drugs. Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, components of AirSupra. Discontinue AirSupra if the reactions shown on the slide occur. AirSupra should be used with caution in patients with certain coexisting conditions such as convulsive disorders, hyperthyroidism, or diabetes mellitus, and in patients who are unusually responsive to sympathomimetic amines. Significant hypokalemia may occur in some patients from use of beta-adrenergic agonists, and possible immunosuppression and potential worsening of infections from the use of inhaled corticosteroids could occur. Use with caution. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Additional important safety information includes oral pharyngeal candidiasis has occurred in patients treated with ICS agents. Advise patients to rinse their mouth with water if available. Hypercorticism and adrenal suppression may occur with very high doses in susceptible individuals. Reduction in bone mineral density has been observed in glaucoma, and cataracts have been reported with long-term administration of inhaled corticosteroids. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity when administered to pediatric patients. However, note the safety and effectiveness of AirSupra have not been established in pediatric patients, and AirSupra is not indicated for use in this population. The most common adverse reactions reported for AirSupra with an incidence of greater than or equal to 1% were headache, oral candidiasis, cough, and dysphonia. AirSupra should be administered with caution to patients being treated with strong cytochrome P450/3A4 inhibitors, short-acting bronchodilators, beta blockers, diuretics, or non-potassium sparing diuretics, digoxin, monoamine oxidase inhibitors, or tricyclic antidepressants. Use AirSupra with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. Please see the full prescribing information, including patient information for AirSupra, available at www.airsupra.com or at www.azpicentral.com. To wrap up this review of clinical data for AirSupra, I would like to briefly summarize the key takeaways that we covered. AirSupra is the first and only rescue medication approved in the United States for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. In the Mandala trial, AirSupra significantly reduced the risk of severe exacerbations by 28%, and the annualized rate of severe exacerbations by 24% compared to albuterol. In Mandala, there was a significant difference in the annualized total systemic corticosteroid dose with Airsupra versus albuterol, with a 32% reduction in mean annualized dose per patient. Most common adverse reactions with Airsupra are headache, oral candidiasis, cough, and dysphonia. When looking to reframe rescue therapy to help prevent asthma exacerbations, consider Airsupra, a rescue treatment designed to address asthma symptoms and airway inflammation concomitantly. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments about this presentation, please contact AstraZeneca at 1-800-236-9933. For medical information requests and access to other AstraZeneca resources, please visit azmedical.com. You are encouraged to report negative side effects of AstraZeneca prescription drugs by calling 800-236-9933. If you prefer to report these to the FDA, call 1-800-FDA-1088. Thank you for your time and attention. This concludes this program.
Well, thank you, Dr. Burnett, for a very interesting lecture, very well presented. We are for kind of a general population situation. From patients' perspective, most patients don't understand exacerbations, and you've explained it extremely well to those of us who are in the field. But how is so many patients are so sick all the time? How do they know when they're having an exacerbation? Or one or two things that they can say, well, most of them say this is my day-to-day existence. How do they know that this is an exacerbation? Is it steroid use? What is it they can use as clues that they're getting an exacerbation?
A part of what I just discussed on this platform is they're reaching for a rescue inhaler. And they know that the symptoms are warranting them to reach for it. It's habitual to some degree, right? Coughing, wheezing, chest tightness, shortness of breath. It's a habitual kind of maneuver to reach for something to rescue them, right? So, a part of the discussion on the platform tonight is it's their behavior that takes place essentially when the respiratory symptoms occur. And really, truly, it's their reaching for rescue. So they know they're in trouble instinctively when they're reaching for something for rescue.
And can we agree that if they have to use systemic steroids, that's an exacerbation? So if your doctor prescribes systemic steroids for you, that's definitely an exacerbation. And that's one common denominator that I think a lot of people miss. They get so used to it that I think that often they don't pay attention.
Well, we hope that they know that using a systemic steroid means an exacerbation. We hope that they're not so used to getting systemic steroid that they're confusing it for it really being an exacerbation and something more serious that needs to be really fully more fundamentally addressed.
Yeah, we do run into doctors and patients for whom exacerbations are kind of part of a day-to-day existence, and they don't think of that as significant as you've explained it.
That you would expect too. Yeah.
And especially the consequences.
Right, absolutely.
Are fairly significant. The question I have is more of a science question: is does the use of Airsupra reduce the overall use of albuterol?
So interestingly, the way that Airsupra was studied, it was studied compared to albuterol. And so when they looked at reducing the risk of exacerbation, which we just talked about in this conversation, how does one know if they're in an exacerbation? And interestingly, the way that Airsupra was studied in the Mandala trial, looking specifically at time to exacerbation, comparing air super to albuterol, what it found was a significant reduction in the risk of exacerbation for those patients in the air super arm. So if you're looking at it and you're comparing air super to albuterol, we can now say that we have data that shows that using a drug with an inhaled corticosteroid component along with a SABA component tends to fare better for patients in terms of the risk of them exacerbating.
You know, I think, Doc, another question I have, doctors generally use a lot of medicines off label. For instance, there was a long time before I realized that the use of long-acting beta agonists and inhaled corticosteroids was not approved in this country, as opposed to other parts of the world. What is the philosophy behind this country doing something differently?
You know, now that we are evolving, is what I like to call it, in terms of the paradigm of how we think about asthma, of how we educate our patients about asthma, and it's now translating into NAEPP and GINA in terms of how they're providing us guidance as healthcare providers as to how to manage patients in terms of rescue management. We are now shifting the way that even the guidelines are giving us, useful tips and helpful guidance as it pertains to how we are rescuing our patients. I think most of us are familiar with, the maintenance kind of treatment options for patients with asthma as it pertains to NAEPP and GINA. But what was most recently updated in 2020 for NAEPP and also for GINA in 2023 is now how we think about the rescue strategy. And what both of them are in consensus about is that at certain steps of both of those guidelines, it is now recommended to use a SABA along with an ICS as a rescue treatment option. And even GINA itself says SABA alone is really not recommended at any of the 5 stages of GINA. So it is very interesting to see where the shift in the paradigm is really occurring in terms of the guidelines. And it is really, truly how we rescue patients in terms of asthma.
Yeah, this combination in Air Supra is so simple. I'm just sorry I didn't think of it, because obviously there are lots of people who are consistently pulling for their albuterol. Clearly, that's the number one issue. But I think that if you look at the refills for inhaled corticosteroids used independently, you're going to find some fairly tragic results, even worse now over the last couple of years because of a number of dynamics that I think I recognize. And so this is such a simple, I don't know why didn't we think of this? You know what I mean? It's just so.
Well, we used to talk about, wouldn't it be great if we could really use these together in a sense? Because really, when you think about the asthma action plans way back in the day, we were actually asking patients within the asthma action plans, we were actually asking them when they're having an attack, if you will, we were actually asking them to bump up their ICS if they ever felt that they were bumping up on their asthma action plan. Let's just say going from the green to the yellow to the red, right? Each interval of increase on our asthma action plans back in the day, it used to have a little line in there where we could bump up their inhaled corticosteroid. So now all we're doing, let's just say, in terms of Air Supra specifically, what we're now doing is we're combining the ICS with the SABA in one canister, right?
Yeah.
So, theoretically, we were kind of already wanting to do this in terms of how we were looking at our asthma action plan way back in the day.
Yeah, well, I think that's certainly a critical point. I think one of the most important points of your lecture, and I'm really glad to see that you pointed that out, is many doctors don't recognize the potential danger in short bursts of steroids. And they tend to use them kind of willy-nilly here and there. I got a little cough, I'm not doing better. And now that you have pointed this out, I think many of us, certainly maybe myself, I don't want to include myself in that particular category, but will be much more cautious about how we use systemic steroids for relatively minor exacerbations. And I think that's that's an excellent point.
And to know that, you know, mild, moderate, and severe asthma can be highly variable, right? There's a degree of variability within each one of the levels of severity of asthma, whichever a person deems themselves, so to speak. So just reminding ourselves of the high variability, even when you're on background maintenance treatment, even when let's just say you're doing the most you can do on your background maintenance treatment, and you're really compliant and you're doing the best you can and you're getting the straight A's for doing your background maintenance treatment. Even still, people can run into asthma symptoms and they can run into problems, and they can do it in an unpredicted kind of fashion. And the reason is just because asthma is a chronic disease of variability, and it is very unpredictable. And even if you're doing your best, you can still run into problems, and you still may need a better option when it comes to how you're thinking about rescue, which hopefully won't lead to a systemic oral corticosteroid use. I mean, that's the hope and the goal, right? Is that we can keep patients out of the emergency room, hopefully, and out of the urgent care centers, and fortunately, hopefully out of a severe exacerbation that does require an oral corticosteroid.
Yeah, and I think one of the upsides is mild, moderate, and severe persistent asthma have the same mortality rates. And it's because those people with mild asthma don't seem to understand the need for maintenance medicine. That's one thing. Secondly, overutilize albuterol, and thirdly, they're not prepared when they get a serious exacerbation. So being able to provide maintenance medicine as the patient seems to use it, it's always seemed to me to be the most logical approach. Couple of final questions. In closing, can you share some self-help resources for our audience to study further if they're interested in getting more information about asthma?
Well, I do know that Dr. Renee is a huge component of this as well, but the Allergy and Asthma Network is my go-to. I mean, as an allergist, it is a platform that can really show you and guide you in many, many different directions, depending on your level of interest in any particular arena as it pertains to allergy and asthma. And I really find that that is a very useful platform, at least for my practice and my patients, that it's a really good go-to, like a front end go-to. And I also appreciate what you guys are doing, particularly with your organization as well. And I'm sure you probably would want to share some information about AAWP as well. I find that doing things like this in terms of social media type of influential discussions on an educational level, I think are really, really impactful for providers in the community that are truly managing patients in underserved communities, in communities such as African Americans and Hispanic communities, where patients generally tend to have more morbidity and increased healthcare resource utilization costs when it comes to managing chronic conditions such as asthma. But I know that you probably want to share some information as well about the African American Wellness Project.
Well, it's interesting. You should mention the Asthma and Allergy Network. We have frequent meetings with Linda about things, because we know in the African American Wellness Project, we cannot duplicate the kind of information assistance the Asthma and Allergy Network gives out every 10 minutes. And so consequently, our role, as we see it, is to acquaint people with this very important resource. So we certainly agree with you. Well, Dr. Burnett, this is a very good information, very well presented. We really want to thank you for taking the time to join us here. And our little portion of the world, Dr. Renee and I both are working to get the word out about many of these things. And I think this lecture did nothing but help the providers. So thank you so much.
It was such a pleasure. And I hope that everyone enjoyed the presentation and is going to have a wonderful evening.